But the last question actually was on data. And so our next speaker is actually going to talk about data, getting it to modelers faster, right? Making it available for decision making. And we saw challenges in that in the last pandemic for sure. I think we all looked to Hopkins, for many of the numbers that we trusted, but we can certainly do better. And so maybe we can move to the next set of slides. And Britta, are you on? There you are.
Yep.
Can you hear us? Okay, I'll turn it over to you. You're going to talk about Beacon. And thank you.
So thank you very much for the opportunity to introduce Beacon to you today. Beacon is a new program that is based at Boston University Center on Emerging Infectious Diseases, and is focused on the early infectious diseases surveillance space, as well as, transition points during epidemics and pandemics when additional and new data emerges, for example, when a new variant emerges. We are not only focused on the human aspect of infectious diseases, but really looking at this from like a One Health perspective, covering the animal health spectrum, so wildlife as well as livestock, plants and crops as well, and environmental threats. So if you could advance one further. Yeah, perfect. So Beacon is a new program, as I mentioned, and was really founded because of several gaps that were identified during and after the COVID-19 pandemic. So I think these gaps can be largely grouped into, data gaps, technological, gaps, as well as some of the data sharing challenges. And so as we talked before, I think specifically around the data gaps and specifically for this, audience here, the modelers, I think what we saw with COVID was that we really had challenges to collect meaningful data on a global scale that could be used to inform modeling, to inform policymaking, to inform targeted interventions. So it was really hard to get data on a more granular level in certain, regions of the world. It was really difficult to understand some of the data needed to estimate transmissibility. We had problems estimating spread. We had problems also looking at populations at highest risk, who was really affected, what happened when new variants emerged, did that affect different populations at that time? So I think a lot of those data challenges were there even before COVID and now even after, but that's one of the issues that we are trying to address with Beacon. I think one of the other, big challenges, at least for us at that point, that came up throughout the COVID-19 pandemic were technological limitations. And I think part of that was that we were working off public health systems that were really built like a decade, 2 decades ago, and we were not able to scale during a pandemic. So we were not able to keep up with the data curation, other teams we collaborated with actually did the same, trying to get human curators left and right who were going through the data and then generating files after files, Excel files here and there, and then sharing those. So there really the limitations of the data sharing, the data interoperability challenges, as well as the inability to scale based on the old technologies we were depending on was one of the other big gaps that we identified after COVID. And then I think the last part that kind of goes hand in hand with the data sharing is actually that there is more and more lack of systems that actually openly and transparently share their data. So we are seeing that more and more of the systems that were initially publicly available are starting to restrict their data. They are putting their data archives behind paywalls. They are even limiting access to their emerging disease surveillance data. And we have 1 or 2 other or additional companies that actually emerged in that space that actually do quite a bit of data collection and analysis, but only make that available to paying customers. So we really identified that there's a huge gap right now, in that space in regards to, delivering data to the global public health community as open access and as a public good. And these, I feel were the funding principles of Beacon. So next slide, please. So how will Beacon work and what will it do? And where are we right now? So we actually started the development process for Beacon, and we hope that we can launch in spring with our first product. So really, and can you click one more time, please? So really what Beacon will be is like a whole pipeline from signal collection to, like data sharing to you, hopefully the modelers and like the broader global public health community. And so the initial step will be the signal collection, and that part is done through our partners at HealthMap. So some of you might have worked with them before. John Brownstein directs the the computational epi lab at Harvard Medical School and HealthMap. So they are responsible for ingesting all like those digital signals into like the Beacon platform. So they will get their information already getting that from online news aggregators, from online news reports, from blogs, from individuals who submit information. And over time, we hope to build out those incoming or feeding data sources even further. They're currently able to scrape data in 12 languages, and we hope with, like the advances in technologies that, like we will be able to add more languages there to actually really be able to also get data out of some of the data blind spots that we had in the past. Next, please. So then another big part of Beacon is actually the underlying technology, specifically the large language models. So we are working with the Hariri Center for Computer Sciences at Boston University. Yanis Pastalidis leads the team there that's currently developing a pandemic LLM for us. And so really this pandemic LLM will sit on top of several of like the workflow, like steps of Beacon. And one of the first areas it will hopefully be helpful in will be to help us to actually prioritize the incoming signals from HealthMap to actually group them into events, to prioritize them initially, and to also help us, like vet those initial signals. So as you know, in informal disease surveillance, the vetting process is like a very important step because we usually get our information from informal sources. So it's not like a confirmed public health report. So similar to news media, we usually work with, like making sure that we have multiple reports, independent reports that confirm the same event. So this will be one of the first use cases. And the team at the Hariri Center is working on that right now to see how they can group, how they can prioritize, how they can group the signals into events and help us with like that first step of vetting the information that's coming in. They will also help us in, doing internal translations of like the reports that are coming in, as well as helping with some preliminary analysis, longitudinal analysis of data that's coming into Beacon. Next one, please. So then the third really important part about Beacon is that we know that, like many of those data collection systems, they actually can't, function without the proper human supervision. So Beacon will also have one component, which is a global expert network, which will be experts that will be placed globally, and they will provide expertise in their local geography, but they will also bring, broad areas of expertise, either pathogen or disease specific. So this will really allow us to have one layer where we actually can cross-check and double-check all the AI and LLM outputs that will be generated within the Beacon pipeline. But also these people will be the ones who make the final decision of which signal should be posted to the global, public, what should be shared, what is actually considered important to be shared with the global public health community. So we have started to work now with the LLM developers and some of the global experts we're engaging with to also, try to refine LLM outputs and really, train those models to deliver what we need them to deliver. Next one, please. Again, some more work for the LLM models, together with the subject matter experts. A lot of, what we are hoping that these models will also accomplish is that it will produce reports that are, for example, multilingual. So right now we're working on all the UN languages as well as Portuguese to make sure that really, people locally can use those reports. And then these reports that will be published on the public facing webpage will hopefully also be supported through some additional resources that can be used to be better prepared during emerging epidemics. And one example for that would be, so my background, I'm an infectious diseases physician. So I'm very excited that we are actually right now talking to UpToDate to see if they can make some of their clinical guidance, infection prevention and control guidance for high priority pathogens available open access through the Beacon platform. And next one, please. And so I feel like this is, our vision for the future. So after, the MVP launch in spring of 2025, some of the teams we're working with are looking into, how to really move more also into the prediction and forecasting space and generating different use cases, integrating additional data sources. Next slide, please. So just to kind of summarize again, so we really hope that Beacon will be a tool for the global public health community. And over time, we hope to build that community that also, reports into Beacon, but then also uses that open access data. We want to be transparent, fast, and One Health focused. Free of political and commercial constraints. And then we are committed, and our funders are also committed to have us operate as a global public good, meaning that we can make that data freely available for, not only modeling, but also research, training, and other purposes. Next slide, please. And with that, I'm ending just to thank our funders, including the Bill and Melinda Gates Foundation. We have several technical partners and collaborators on board already to help us navigate the data interoperability landscape and to make sure that really the data that we are producing will be used by public health practitioners around the globe. We have several advisors. I want to highlight Marjorie Pollack here. Some of you might know her. She was the former ProMed deputy editor, and she was credited to alerting the world not only to COVID when it was still pneumonia cases of unknown etiology, but also before that MERS and several other emerging pathogens. So we really are trying to bring all of her knowledge of that decade-long experience working in that space into those new, pipeline and how the large language models can actually really help us pick up on more needles in the haystack as she successfully did. And with that, I'm closing and I'm looking forward to questions. Thank you.
Thanks, Britta. That's a great vision. Maybe I'll again take the priority to ask the first question, and it's going to be similar to the last question I asked, or the first question that I asked Arminder. Is how do you think about sustainability of this? It's going to be a great resource. You have good funding now, but a lot of that funding is not endowment funding. So how do you think about sustainability?
Yes. Excellent question. And I think it's one of the biggest, questions on our mind as well. We know it takes time and effort to build sustainability in these kinds of programs. So we are fortunate to be supported through Boston University. They are actually investing also a significant amount into the development of Beacon. And Nahid Badelia, who is the director of Beacon and also the director of CEAD, the Center for Emerging Infectious Diseases at Boston University, is currently also working with the president to see if we can work towards an endowment for Beacon. We also understand, while we are kind of in a more startup phase right now and really, developing the technology and getting everything off the ground, we do hope that the moment we are able to generate data, that will open the pathway to collaborations and funding through other sources, more like project and based, funding as well. So we are definitely working towards that as well. And we are also exploring if there are potential, parts of the data that could be interested to paying partners. But again, we really want to make sure that we are walking that line to making everything that's needed for the global public health community available open access, but maybe repackaging it in different ways for some of the commercial partners. But definitely an ongoing issue, and any input also from your side is appreciated.
Okay, maybe in the back, please.
Okay, thank you so much. My name is Vera Chenge from Nigeria, and I would like to ask a question with regards to the pandemic element. How do you see incorporation of the low-resourced languages, which is mostly the case for African countries? Is it something you're taking into consideration into the pandemic element?
Thank you. Could you, David, could you repeat the question, because I had a hard time hearing it?
Sure. The question was about languages that have less
Languages.
Yeah, low resource languages in Africa mainly.
Yeah, and thank you for that question. So definitely, I think, like, we do think that the large language models provide an immense opportunity to bring to not only collect, signals from more languages than we already do right now, but also to push out, reports in more languages. For right now, we are focused on the 6 UN languages plus Portuguese to cover those, and then hopefully in later phases more languages. I think our main limitation here is really the limitations of the large language models that we are using. So right now we are trialing one of the large, open access large language models as well as some of the commercially available ones, and those function very well in certain languages, but the less used the language is, the more problems we have applying that. So I hope as this field overall, develops further, that we will be able to add more and more languages.
It's a really good question, and certainly has implications beyond just modeling. So I think as a foundation, we're interested in that too, and are looking at solutions. Okay, please.
Yeah, thank you so much. This is a great talk. I think one of the places you would benchmark in terms of building such a great project is the COVID-19 dashboard from Johns Hopkins University that was very resourceful during the COVID-19 pandemic. They faced a number of challenges, more so in implementation, so we want to interact with them. I have a colleague of mine, Dr. Esheng Deng here, one of the people who are behind that COVID-19 dashboard at Johns Hopkins. But one of the things I wanted to bring is that during the COVID-19 pandemic, we were retrieving such reports from that high-level data collection centers like the COVID-19 dashboard. Now, one thing that our policymakers wanted was kind of a quicker dive or a deeper dive from what those reports are saying. And we always wanted to retrieve raw data, data which is behind what we are seeing in the summary reports. Although you're saying that data will be commonly open access and readily available, but there may be steps like, say, for example, you apply and then you have to keep waiting until the approval will be made or until you be allowed to access that data. So just a comment, but also a concern. Yeah.
Yes, and thank you. We completely agree with that. And I think, again, one of the major limitations, the curation of that data out of the reports, out of the summary reports, and really sharing them out. We had a lot of delays in that process. Again, I feel like it's too early for me to really predict how that can be solved by the LLMs, but we do think that at least the preliminary results we are getting right now, it might be a mechanism to extract that data much faster than what we did before.
Hi, thanks very much for the talk. My name is Amy Paul from VitalWave. I wanted to ask a question about building trust in data. One of the issues is, how do you know that this is a trustworthy signal or a trustworthy, data source that we're then carrying forward? And you mentioned in the workflow, relying on subject matter experts and keeping that human in the loop. But I wonder if there's also a goal or a planned effort to come up with some kind of standard or certification or standard criteria for what makes something worth going forward, or what you should expect of the data that went into the model, or the process through it was developed, or the performance metrics that it produces, that could be something transferable in terms of how do we know we can trust the signal?
Yes, and that's definitely something we are thinking about right now. And as a first step, like one of the things we're trying to do is really to look at the different sources these signals come from and attaching some sort of reliability, like score to that or level. I think again, like for us working mainly in the informal disease surveillance space, there is a lot of misinformation. There is a lot of, like misinformation that gets amplified in that space, and really how to, like verify reports that come in through trusted sources is one of like the pieces we are working on right now. So I feel like for this first part of the work we are doing, really, like making sure that in the end, like if something gets published on that web page, for like the user to know that went through like the verification process. And there is really, like there is something, at least we, the human experts behind it, think there is something behind that, will be like the first step. I think then really if it moves over time more into like the predictive algorithms or integration of additional data streams, that definitely needs to be, like addressed at that point as well.
Yeah, thank you. My name is Samuel from Nairobi. Mine, just a comment to say this work is very promising. We have been doing some work on InBridge, actually for CDC. We got InBridge, where we compare the event-based surveillance, like signals, like happening in the communities and other places, and now try to link those signals with the evidence-based data set from like Kenya information system. So to me, I think this is very interesting and exciting. And I hope it's something we can replicate, like the work we are doing in CDC, because our work is just minimal in terms of machine learning. But I think this has a broad, I think it's more broad in terms of application. So thank you so much.
Thank you. Thank you.
Any other questions? Okay. One final question.
A question. Even from the leadership here, I'm concerned the focus is more into the global north. Do you have some efforts of getting information from the global south, but also getting experts to validate or to input from the global south as well? Because in terms of capacity building, we would be engaging some of them at this level of developing tools and these products such that they can also do the same in the global south areas in the future.
Yes, absolutely. And so, like from every aspect of the program, that's like high priority. So again, like the data collection, we do, like envision that will be a global data collection. Some of the limitations in the beginning will be that it will be constrained to like currently Health Map collect signals in like more than 12 languages. But so that will be, like one of the factors that, like how fast can we build out or integrate more languages and, like scrape more information from online available, like information that's online available. In regards to the expert network, yes, that will definitely be a global expert network, and representatives from the global south will be part of that expert network. We think that's extremely important, and that's one of the highest priorities as we start onboarding those experts over the next couple of months. And then ultimately, Nahid Padelia, who is leading Beacon, she has like her vision is also to really provide training programs, like locally, like where people can use that data, but also get trained up in the LLM technologies and the limitations and the use of like the technologies behind Beacon. All the development code also for the LLM refinement, or like what is planned right now will be made open access on GitHub. So really this commitment to open data sharing and to really using that as a like initiative that hopefully will also help to train across the globe, that will support research that will support the global public health community.
Okay. Join me in thanking Britta again. And yeah, thank you, Britta.
Thank you.